So my name is Joe. I'm one of the clinical nurse specialists for the alcohol care team. What I've come kind of to talk to you about today in the kind of context of ADH is the stigma and the kind of preconceived notions that we hold against people who suffer from substance use disorder or alcohol use disorder. I think we've all anyone who's been on the shop floor has kind of had those experiences or preconceived notions, like I say. But first off, who are we? What do we do? We are the alcohol care team. So previously known as DALT, probably referred to us quite a few times. We see all the kind of drug and alcohol type patients in the hospital. If anyone comes in with a condition that's relating to alcohol withdrawal, chronic alcohol use, drug withdrawal, chronic drug use, that kind of thing, we'll assist with their care and deliver that specialist advice. So, like I say, there's a lot of stigma around these individuals. When we hear the word stigma, a few things kind of spring to mind, and I've got a few of them kind of knocking about on this. Shame, so that idea of like shame, whether it's self-shame, shaming, that you feel against yourself. Judgment, again, whether that's self-judgment or judgment from staff. Judgment from the public, judgment from visitors just coming in. Poor engagement. We know that this population of people are notoriously hard to engage with, often having kind of severe multiple disadvantages, as well as just the drug use or the alcohol use, things like homelessness, which makes them ever so hard to engage with. Got a bad reputation. I think everyone's probably got a story about looking after someone who's got substance use disorder or alcohol use disorders, and it's been a bit challenging. I will say, since working within this team, I've never had to deal with any kind of physical aggression. When I worked on D11 as an AMP5 nurse, it was a running joke that I had a punchable face. There was that many nights shifts spent down in A&E after being assaulted. It's not even funny, but we can look back and laugh now. When we're talking about stigma, there's loads of different kind of categories of stigma, and I could stand up here and talk for ages about them. But the two main ones are public stigma. So that is the perception of a group or individual from the public eye. So how we perceive a group or an individual. There's also self-stigma. And that is the individual taking on this stigma and kind of preemptively expecting that perception. So public stigma, where does it kind of come from? Does anyone hazard a guess? Where does that kind of public stigma come from? Where do we get this preconceived notion?
What comes into society, you see drug addicts now poets in the streets and you think they're going to do something for good. Except principal class America right now. Yeah,
by now, yeah. So criminality, laws, policies, our own kind of lived experience. We're kind of taught to stay away from these people because they're drug addicts, they're dirty, they're criminals, they're this, they're that. Media outlets, we get coverage of one story, it then gets spread around, it becomes all of our story. We take that on and say like, right, even though we've never personally experienced it ourselves, we take that on as kind of quite personally. So self-stigma refers to people taking that on board. Okay, so they're aware of that public stigma, they're internalising it, and then saying, well, everyone thinks I'm like this, so I've kind of got to either play up to it or no one's going to treat me well anyway. That kind of leads us into this cycle. When an individual takes on the public stigma and becomes self-stigmatised, they anticipate hostility towards them and become more sensitive to any language or behaviour that can be interpreted as judgmental or stigmatising. So that self-stigma kind of perpetuates that cycle. They will become hypersensitive to any kind of language, any kind of behaviour that people think that they think is derogatory towards them. This anticipation kind of fosters that sensitivity. Yeah. So, like I say, not to labour the point, but they expect that that stigma towards them. They expect negative treatment, and then they're more likely to react poorly when something may be said in innocence. Or maybe if there's a delay in medication, sometimes when you're a busy nurse on ward round, you're trying to get everyone's CDs out, and there's a patient picking up because he wants his methadone. What he's seeing is a healthcare system that he thinks that doesn't care about him because he takes drugs, because he's on methadone. It doesn't see that, you're a nurse, you've got a full day of patients. And it's about kind of breaking down those barriers and communicating. And only then can we kind of try and break that cycle. What we're up against. So there's a lot of barriers with stigma. There's some quotes here that I'm sure we've all probably heard in our practice. They've done this to themselves. They won't get any sympathy from me. They chose this life, that kind of thing. All druggies are criminals. Drug people are violent. They're just here for drugs and meds, med seeking. We get a lot of calls about people that are med seeking. They're not in pain. They're just a junkie. They're just on heroin. They're not in pain. They just want to get high. We don't kind of recognise that this is a population of people that have to have, say, sometimes 50 to 100 milligrams of methadone, a very strong medication, very strong opiate medication, just to function normally. And that just keeps them from withdrawing, keeps them ticking over, keeps them from clucking, as they say. And then they're coming in with an acute illness or they've broken their leg. Of course, they're going to be in massive amounts of pain. And then we're not giving them pain relief because we think they're on too much already. So it's kind of like challenging those ideas that we kind of hold quite close as nurses. We want to keep people safe. We want to keep people from, we don't want to over-sedate people. We don't want to knock people off and make them drowsy. We don't want to kill anyone. But we need to recognise that this isn't a normal kind of cohort of patients that we're caring for. Do we ever ask why the person takes drugs or drinks to excess? Not really. No, you do. Yeah, that's always good. It's always good to kind of start that conversation because it's not a problem in itself, it's a symptom of a deeper problem. No one takes heroin because everything's great in their life and everything's going perfect. No one drinks to excess because they're completely happy with everything. People use substances as a attempted solution. People take heroin to deal with the fact that they're a sex worker. People take crack cocaine to deal with the fact that they're homeless. People drink to excess to escape their abusive relationship. There's always something deeper. And that's what we're not thinking about when it comes to these patients. So what? So they make up a very small percentage of the hospital population. In terms of the UK population, I think it's about 1 or 2% are alcohol dependent in the whole UK. In Nottingham, we're slightly above average, we're about 2.5%. So these people are there. They are a population of people that do come into hospital that have healthcare needs. Their risk of ill health is a lot higher due to the associated risks of alcohol and drug use. So obviously we know that alcohol use, chronic alcohol use, damages your liver, damages your body in all sorts of different ways. There's also the associated risk with drug use, whether that's IV or smoked, heroin, that kind of thing. There's the risk of infections, abscesses, all that kind of thing. There's the risk of hepatitis, HIV, spreading those diseases, things like that. There's population with some complex and serious healthcare needs, and they're at a disproportionate risk of death due to that. Whether that be through death through misadventure or death through overdose, whether that be, like I say, misadventure, whether they mean it or they don't mean it. as an attempt on life, or through an increased risk of suicide due to poor mental health. So it's a very challenging area. It's a very kind of complex area. What can we do? What I'm not standing here saying is that we should tolerate everything, that we should tolerate aggression, violence, harassment, bullying, any kind of thing towards staff, towards each other, towards the patients, things like that. But sometimes it pays to kind of dig that a little bit deeper. Why is that patient acting in this way? Should we do anything? Again, our stigma against this population would say they've chosen this life, but have they? Have they chosen it, or has it been kind of forced upon them? The majority of people that get into heroin report that it was a friend that kind of coerced them into doing it. People are victims of grooming. Why are we holding this kind of against them? Why are we tarring them all with the same brush, saying the criminals, they're this, that, and not treating them equitably like we would do with any other patient? Why are we doing that? Like I say, we shouldn't be tolerating any kind of violence, aggression towards staff, towards the patients. But what we can do is kind of take that step back and just say, why is this happening? What can I do to help? What kind of awareness can I have? Okay. Throughout all the literature involving stigma around substance use disorder and alcohol use disorder, the running theme is a problem that can't be solved overnight. It's not something that we can just do a big teaching session on. I can't go around to everyone and say, don't do this, don't do that, and then it's solved. It's very much a societal problem. But things like bearing in mind just compassion, the language that we use it. So you've noticed I've not said alcoholic. We try and steer away from calling people alcoholic or, alcoholic liver disease. It's alcohol related liver disease, alcohol use disorder, that kind of thing. It's changing that kind of aggressive, blame putting language into something a bit more accurate. Okay. Empathy goes a long way. Equity, so again, treating people equitably, easy for me to say, as we deal with all our patients. Communication. Education, so again, like I say, it's not something that can be solved overnight with just a quick teaching session, but something like this is fantastic. We can get out there, spread the word, and hopefully you can disseminate all this to your areas, and that'll be fantastic. Inclusivity. Again, I think it's just echoing what everyone else has said during the day about building that inclusive, equal culture within NUH. So why have I kind of been talking about all this? Stigma creates a barrier to treatment. People who are stigmatized feel will be less compliant, will be less likely to seek treatment. Again, with their poorer health outcomes, if they're less likely to seek treatment and they're delaying the presenting to hospital, that we're risking people's conditions getting worse. We hear stories all the time about people in the community that have got horrendous abscesses from injecting. They don't want to come into hospital because they know they're going to be treated poorly by staff. And that's something we're trying to fight against all the time. We're trying to get people in and say, look, we will be there when you come in to sort out your methadone. You're not going to go into withdrawal. We're going to keep you comfortable. What we want is for you to be safe at the end of the day. We want you to be safe and we want to treat you for this. Okay? Prevention is better than cure. That's kind of sums it up, really. If we're able to understand why people are behaving a certain way, we're able to kind of communicate more effectively and build those therapeutic relationships. So if we're able to understand where someone's coming from when they're kicking off, we can kind of communicate better with that. We can have those meaningful interventions. An example I always think of was when I was a band 5, I was working on the burns unit. There was a bloke there being discharged, not one of my patients. I came out of the drug room and he was shouting, screaming, he was being horrendous to staff. He was really threatening people, being awful because he was being discharged and he brought in some of his own methadone. So we'd taken that off him, put it in the drug cupboard as per policy, absolutely fine, but he wanted to take that home with him, it's his property, and we weren't letting him. The reasoning for that was, he's a drug user, he's going to go home, he's going to take that, he's probably going to take heroin as well, and he's going to overdose and die, and then that's our fault. What we weren't seeing was that that's his property, he's more than entitled to go home with that. If he doesn't go home with that, he's got a community pharmacy that probably knows that he's got that methadone and won't prescribe him anymore, won't dispense anymore until that next script is up. So he's potentially going a week without any methadone. It's not going to kill him, but it's going to make him feel horrendous. It's going to put him into some of the worst withdrawal that he could have. And he's got two options then. He can either ride that out and just be in withdrawal, feel horrendous, feel like he's dying, or he can go and use street heroin. And that's a choice we're putting on him by withholding that methadone. At the end, we didn't give him this methadone. So he went home. I don't know what happened to him after that. But it's something that we're not bearing in mind. We're not thinking about that. It's something very simple that we could have done. We could have spoken to. Again, I was a band 5 staff nurse. I wasn't aware of all these things that I am privy to now. But we could have spoken to the community pharmacy. We could have liaised with his key worker, things like that. Referred to the drug and alcohol team. All those kind of things, all those interventions that could have prevented all that from happening, and we would have avoided that whole escalation of that event. So it's like I say, what I'm not saying is that we should be tolerating things, but taking a step back and looking at why that person is behaving that way. So there's a lot been kind of covered in quite a small amount of time. There's a lot of kind of complex ideas, like the ideas of stigma, the different types of stigma. The main takeaways, if nothing else, is that what we do and what we say matters in ways we don't often realise. So how we say something, how we talk to someone, even something simple as, like I say, talking to someone first thing in the morning saying, I understand you're on methadone. I've got a lot of patients to sort out, but you are high on my priorities. We're going to get you that as soon as possible because I don't want you to be uncomfortable. That lets them know what you're doing, makes them feel valued, makes them feel that they can trust you, makes people feel safe, cared for, confident in the care that they're receiving. Yeah. If someone was withdrawing from alcohol, you wouldn't kind of put off giving their chloride peroxide because you know that's dangerous. It could end up in them. They're going into the DTs, they could have seizures, they could have a fit. Why put off giving methadone just because someone's kind of kicking off a little bit? Just, like I say, taking that step back, thinking, why are they acting like this? Okay? Like I say, we absolutely should not be tolerating any kind of abuse to staff. But having that awareness is always a great tool. Early intervention can reduce these instances and encourages compliance with treatment. If we're getting people more compliant with treatment, we're building trust within that community. We're potentially saving millions in bed days because people are coming in and not requiring surgeries for abscesses, surgeries for clots, 3 months on antibiotics on Nightingale wards, and they're not needing that because we've caught it early, we've intervened, we've gained their trust. And if by doing that, we're also reducing instances of agitation, aggression, violence towards staff, then that's amazing, that's even better. And if in doubt at all, refer to us. We'll always just come and support. You can do the referral on nurse centre, nursing referrals, drug and alcohol referrals. We aim to see everyone within 24 hours. And we'll always be there to be that mediator. Yeah. Reducing stigma does work. I know sometimes it's hard to take that on and say, like, why are we putting up with this kind of population of patients? Why are we putting up with this behaviour? Reducing stigma does work. So by reducing the stigma, by getting people engaged with the needle exchange, letting them know that there's a safe place where they can come in, exchange their dirty kit for clean injection equipment, letting them know that they can come in anytime, they can swap that over. It means that we're reducing risks, reducing instances of hepatitis, we're reducing instances of HIV. We're building those therapeutic relationships by them coming in every day to someone that they can trust because they know they're going to get clean injecting equipment. We're then engaging them in therapeutic services, we're engaging them in community services. We can get them on a script, get them off street heroin, get people stable, get people on buprenorphine, things like that. We can have a real massive impact in lives by reducing the stigma, by swapping from that kind of criminality approach to a more healthcare-centred approach. Thinking of people less as the drug they use and more as a person, looking at them holistically.
It's like breaking that cycle. So we have that stigma.
Mm-hmm.
So we may speak to the patient because we've got a preconceived idea of what you're going to be. So we perhaps don't treat them the way. So then they behave in the manner that we expect, and it carries on going round and round. They have a bit of a self-fulfilling prophecy of you've got this opinion of me, and they live up to it because we're giving them attitude, and you just got to break it.
And then what happens? You go and tell your colleagues on your break. You say, oh, bed 3 was right, so and so. And then they have that preconceived notion of them. They kind of take your story as their own, and they'll say, right, I'm not going to take any crap because of that, which then leads them to feel like they're being treated poorly. It's this self-fulfilling prophecy, like I say.
Just why? This might be but we had a lot of news doctors, especially international, and if they have to refer, now your name only says alcohol and doesn't say drugs, so they might not have the initiative to refer to you. Why has it changed?
It's that if a person is admitted and you go through their admission criteria, they ask the alcohol questions. If that flags up as possibly dependent or high risk drinker, we automatically get a referral, and it's just for alcohol.
What about drugs?
So for drugs, that's a separate referral. Well, it's not a separate referral because we're the same team.
This is where I'm coming from. They might not know that it's you that they need to refer to.
So to refer to the drug and alcohol services, it's just on tasks, open a new task with drug and alcohol nurses.
Because now it's changed to ACT, so maybe we need to share out there.
Yeah, absolutely, and that's what we're trying to do. We're trying to get our name out there. We're present on pretty much every award. We
need some publicity.
So what's the ACT? What's the C?
Historically, we were always called DOL.
Drug
and alcohol liaison.
Yeah.
Alcohol Care Team is a national kind of initiative that's been set up to try and reduce instances of alcohol admissions, things like that, improve our health outcomes. That's where our money comes from, so that's what we're called.
Is it your team known for the community?
Yes.
Because I've got to say, because I've been to mental health training, but we help out in there, what you're able to say, we get some of the classifiers, does that make sense?
Yeah, sure,
They say, okay, passing cordial, or openly cordial, or what people don't say mental health, or mental health, something like that. But a lot of time, mental health, if they don't get involved, there's something to look out for. That's obviously quite explanation. There's some more go back and forth. So don't think, I've been running for inside community mental health team, because it's supposed to be a temple particle. We have to look at communication therapy, talking therapy,
they're the challenges we face as well. So we're very much of the opinion that there's a root cause. Identifying that root cause, helping with that root cause will then have a better effect on the it's difficult to engage in those services if you are intoxicated, if you are dependent on alcohol. Yeah, 100%. Yeah, and that's the difficulties we are facing. But we can only do what we can do, and we'll try our best to treat them in hospital, and then try to get them to engage in therapies when they feel ready for them.
I've been trying to find a community space like a rehab place. I think what's today forever, but I can't find anything like that. Like a place where there's no real education setting. Not NHS, obviously, dad's got no money at home to help get it fun. Doesn't have to need 14 days. We couldn't make it. Hospital's great.
Yeah.
But that's not always going to be the most effective way to
Yeah.
So we have to 24 days. But sadly, that's the point. And you come home again and it's important. That's where you find out.
Yeah. So
it's been broken leg and up you go.
yeah, there are options. It would just be engaging with the community services that will be able to sort that out. So depending on where you live, dictates which community service you're staying to. If you're engaging with them, they can then sort out referrals to inpatient detox. The big one at the minute around this area is called the level. Yeah. So anyway, we've got 4 beds there that we can do our F21 pathway to and all that kind of stuff. But there's very strict criteria for that. Going into a community detox is less criteria, but it takes longer. Yeah. So yeah, there's nothing. We're very limited as to what we can do, but we'll do everything we can. Just if you ever need any help with anything, just give us a call. We'll try our best. Was there any other questions?
No, thanks, Jay.
Thank you.